Our next speaker is going to talk about cough. What can we do about it? And those that have IPF know about coughing, and some of you are coughing in the room already. So, Dr. Daniel Marinescu is from the UBC Department of Medicine, and he's not a stranger to this forum. He's talked a couple of years now. And Dr. Daniel has received his medical degree from McGill University and completed residency training in internal medicine and respirology at the University of Toronto. He then completed a 2-year fellowship in interstitial lung disease and a Master of Health Science at the University of British Columbia with a focus on epidemiology. That's a tongue twister. And clinical research. He is a clinical assistant professor in the Department of Medicine at UBC and works at the Centre for Lung Health and Vancouver General Hospital. He has an interest in imaging and interpretation of CT scans as it applies to diagnosis and prognosis in interstitial lung disease. Whew. So welcome, Dr. Marinescu.
Perfect. So thank you very much. It's a pleasure to be here again, a pleasure to see everyone. I knew I was going to get ripped on by Dr. Ryerson as soon as I was... anyways, I apologize. I mean no disrespect. I'm on call at VGH now, so just juggling between a few things to be able to be here in person, because I think these things are a lot nicer to do in person rather than doing over a Zoom call. So you might see me run out of here a little bit after the panel kind of quickly, but I'm sure Dr. Ryerson can field questions. I taught him everything he knows. So chronic cough. Okay, so cough in ILD, we know several things about it, and the people in this room know this most about it, is that it, number one, decreases quality of life. It's an extremely annoying thing to have to deal with. In some studies, it's actually been associated with worsened disease, more progression of disease, although that's not uniform across the evidence base. And it's extremely frustrating to everyone involved. And I actually wrote and erased and wrote back and erased the last part in brackets here because it is extremely frustrating, first and foremost, to patients and then their caregivers. And believe it or not, to us as well, mostly because a lot of the time we feel a little bit helpless with it. And we do the best that we can, which I'll outline going forward. But a lot of the time, we unfortunately don't have that golden magic bullet that we wish we had. So here's our, the cause of this chronic cough, I should say first, is usually multifactorial. And multifactorial is a fancy way to say we're not really sure most of the time. But we can talk about the things that we think are most likely to be contributing to cough, and then basically attack each of those things as best as we can. So in terms of that multifactorial cause of your cough, we think about the most common things that lead to cough, even outside of ILD. So these are the most common causes that cause chronic cough, even in patients without scarring in their lungs, and they are reflux, postnasal drip, and asthma. And the idea here, especially behind the first two, is that either heartburn or reflux, something comes up and tickles your lung, and then you cough. Or postnasal drip, something is dripping down from the back of your throat into your lung and it tickles your lung and then you cough. Asthma is just because asthma is as common as it is also on this list of common things. Beyond that, we have the ILD itself, which can be the scar or the inflammation that's there, depending on exactly what subtype of interstitial lung disease we think you have. And that certainly contributes, and that's a lot more difficult and sometimes impossible to really tackle. And then the third major thing, what's really important on this slide, is this increased sensitivity or hypersensitivity to cough that can develop over time. And I'll tell you a little bit more about what I mean by that. So this is your normal brain-lung circuit, neural circuit, I should say. And there are neurons all over the place that are telling the brain what the lungs are doing and how the lungs are feeling. And let's say you get a pollutant that you're breathing in, and that's going to stimulate some of those nerve endings and some of those receptors. And it's going to tell your brain, hey, there's something going on here. Your brain's going to go back to your larynx, and it's going to say you need to cough to get that harmful substance out. The problem here that happens over time with any of those causes of cough is that if you cough enough for any reason, you start to sensitize this whole circuit. So you have repeated cough day in and day out for any reason, whether that's heartburn, postnasal drip, lung scarring, what have you. You sensitize this reflex arc, and then you start to be able to cough with minimal or no stimulus. So the same kind of the same kind of thing that otherwise you would have kind of brushed aside in terms of an inhalant that causes you to cough, now is really sending you going and going into a coughing fit, for example. And that's, I should say, we'll get to it, but that's notoriously difficult to break that reflex arc and that reflex circle. So how do we do this? We try to treat each of these things and basically go down this list. And that's most of the time what your doctors are asking about when you're talking about cough in clinic. So we ask questions about heartburn, postnasal drip, asthma, and then we think about other things that we reach for after trying to attack these common entities. So let's go through them one by one. In terms of heartburn or reflux, so this diagnosis, I'll put in kind of quotations, there's no objective test for a lot of these things, which is also why it can be feel a little bit flimsy or a little bit difficult to try to figure out exactly how best to help. There's no real test that you can commonly do and say, hey, you tested positive for heartburn. But we go basically based on your symptoms. And especially if you're having that burning sensation up your chest, or you're burping, or there's that sour metallic taste in the back of your mouth, or it's recurring with certain foods that you're having this, we kind of hum and haw and we think, hey, there's probably some reflex going on here. The non-drug approach to this, which is really what we stress first, is avoiding large single meals, so more frequent meals during the day, no meals 2 or 3 hours before bedtime, as well as sometimes people get a lot of benefit from a wedge pillow, and that's a beautiful image of a wedge pillow. Basically what it's doing is that when you're going to sleep at night, instead of having all that content kind of level with your when you're sleeping in bed and kind of coming up your esophagus, or your food pipe, you have the pillow that is kind of using gravity to direct that back down and try to help with that. So those are really nice because those don't involve any drugs. You can do those. It's always tougher to make lifestyle changes, but it's always probably more bang for your buck and more effective to make lifestyle changes than just than most any medication that we have to give you. The drug approach, there's certainly over-the-counter stuff, Tums, Gaviscon, we all know those things. And then there are prescription antacids. And a lot of the time, the easy thing for us to do is to reach for a prescription pad and give you an antacid. And it is relatively benign. There are always some risks and benefits to all of these things that we do, but it's relatively benign. And if, as you'll see in a lot of these conditions, if we feel that there's a chance that this might be contributing, it's usually a reasonable thing to try out and see if it helps. Okay, postnasal drip. Same as heartburn. There's no test that'll come back positive for postnasal drip. It's largely based on what you tell us. So kind of secretions in the back of your throat, this tickling or itching throat. Oftentimes people will describe this need to clear your throat. And if we think that there's an element of that going on, we do the same thing. We try a non-drug approach first, and some people get a lot of benefit from nasal saline rinses. And this is basically just cleaning out and keeping clean your sinuses so that you're getting rid of all of that stuff that might be dripping down into your lung and causing cough. These are things like the neti pot, like the Neilmed sinus rinse there. There's other ones that are kind of ready-made for you, like the HydraSense picture there that you can sort of just jet into your nose. I've done this. I actually really like it. I'm probably one of the few that really likes it. But you'd be surprised if you get into a routine of doing this. There are some people who come back to me and say they love doing it because it does give that feeling of kind of cleanliness and helps with their cough. So it looks painful. It is not. I would certainly try it if you have any of these symptoms. In terms of a drug approach, there's anti-allergy drugs, so usually antihistamines. So things like, this is the generic name for Claritin, I think, if I remember correctly. So your over-the-counter antihistamines if you have seasonal allergies that's contributing to nasal symptoms. And then we have topical things, topical medications for the nose and the nasal mucosa, like topical steroids, The idea behind these, and especially topical steroids, which is the thing that we reach for as physicians most often, similar to that antacid prescription that we reach for, this is the thing that we reach for the postnasal drip side of things. The idea is that the steroid that just sits on your nose thins out that mucosa, so that that lining that is there and producing your mucus and secretions is doing less of it as it thins out over time. And when there's less of that, presumably you have less postnasal drip. Okay. Third thing is asthma. This is a difficult one in ILD. This does have a more objective test that comes back and with a rubber stamp that says, hey, you have asthma, and that's by the breathing test that you do in clinic all the time. The difficulty with this in ILD is that some of the numbers that you look for to try to observe asthma on there are actually confounded by the way the ILD itself is affecting those numbers. So it becomes difficult to tease those things apart perfectly. And so we look for other clues like a history of childhood asthma or certain markers on your blood work. But sometimes you can have two things at once, both asthma and ILD. It's not super duper common, but it exists. Really, the best solution for this is an inhaled steroid. The same way asthma is an inflammatory condition in your lung, you can think of it as a fire like embers, and your steroid, inhaled in this case, is like your fire extinguisher. And it works quick, it works well, it's not systemic, so it doesn't cause all the terrible systemic side effects, and it really cools those embers and keeps things under control. So I should note that second point there is important. This doesn't help your ILD. If you have ILD, you should not routinely be on a steroid. This should be done in a very thoughtful manner if there is the idea that there's underlying asthma there as well. Okay, so some key pearls about these common coexisting conditions. It's difficult to know if and how much each of these conditions contribute to your chronic cough, but because they are low-hanging fruit and have relatively benign things that we can try to make things better, we go after them. So that's this next point. We often try to treat one or multiple of these in case there's an element of it. And the risk-benefit, I would say sometimes, maybe even usually, favors trying them. And really the key, and this is probably one of the most important points for you guys for this, is that consistency is key. All of these things, whether it's an antacid, whether it's nasal rinses, whether it's your inhaler for asthma, if someone very thoughtfully thinks that you also have an element of asthma, all of these things do not work after 1 shot or 2 shots or 3 days. These things take 4 to 6 weeks usually of giving things a fair shake with regularly doing them before your body kind of rejigs itself to see what the effect is on that cough. Okay, number 2, the interstitial lung disease itself, the scar or the inflammation that's there. So there's differing studies out there. The big trials that Dr. Ryerson just presented in terms of the things that led to nintedanib or pirfenidone, those big trials did not show an improvement in cough. Subsequent studies that have looked backwards or coalesced multiple of those trials put together seem to suggest the signal that there might be a little bit of a benefit to cough there, but it's not huge, but it may well be there. All that being said, we're going to be doing antifibrotics, for example, or anti-inflammatory medications, regardless of the cough, because we're targeting for other reasons for that lung decline. So these aren't necessarily, these may help along with everything else that we have in our armamentarium for ILD, but they're not strictly directed towards your cough. Number 3. So number 3 is this increased sensitivity to cough that can develop over time with any of these conditions, this reflex arc that is very difficult to break. The goal here and the drugs, there are a few non-drug items that can help with this. Sometimes referral to a speech-language pathologist can be helpful to train your vocal cords or train your larynx for cough suppression. And there are programs for that are suited to specific people who have difficulties with that. So that is, and I don't have it on the slide, I apologize, but that is a reasonable non-pharmacologic thing to do. In terms of our pharmacology and what we have to help with this are drugs that basically dampen this neural reflex. So the first and the thing that we have the most evidence for is opioids. And the same way that opioids dampen your neural responses to pain, that's how they lower your sensitivity to pain, they also dampen your neural responses to that need to cough, that flickering of that neuron that's telling your brain that something is going on in the lung and you need to cough. There is good evidence for this. So opioids, I mean things like morphine, things like hydromorphone, things like codeine, things like oxycodone. There's a whole bunch of them. There is good evidence. I've shown one figure from one of the trials on there that we have. It was called the Pacify Cough trial. It was in 2022. What they did is they took a group of, I think, about 40 people, and for 14 days they had them on an opioid, and for 14 days they had them on a placebo, and they looked at what their hourly rate of cough is. And you can see that blue bar over here. Let me see if I can have a pointer. There we go. That blue bar over here, this is at the beginning of the study for the arm that was on opioid. So they're coughing about something like 22 times an hour. And then when you're on the opioid at the end of the 14 days that you're on it, you're coughing about 12 or 13 times an hour. It's about a 40% decrease. And meanwhile, if you're on placebo, there's not much change between the start and end of that trial. So we have good evidence for it, that it works. I think there's a lot of fear around opioids, as there reasonably should be in some cases. There is a risk-benefit calculus to be made there. And opioids aren't by no means benign, but they are a helpful line of defense when cough really is lowering your quality of life. And there is a safe and reasonable way to approach it, the same way as there is in any condition that necessitates opioids. If you have a lot of pain, we're not going to withhold opioids because we're scared of X, Y, or Z with opioids that we've seen a lot in the news. The main side effects here to worry about are first and foremost constipation. Often that won't be a problem if we're also on nintedanib. Nausea, and then if you're taking too much or you're taking too much all at once is what I should really say. Some lethargy, some somnolence. If our approach really is to start low and to go slow, because that's what really fights off, especially that last one in terms of being too lethargic or too somnolent. And I usually have individualized plans with people. It depends on what you want to get out of it. There are instances where some people are particularly sensitive to, for example, going out for dinner and knowing that they're going to be out for dinner with their families, and 30 or 60 minutes before you know you need to go to dinner, you have this on hand that you're able to use, and you use it almost as a pill in pocket, kind of as needed basis. And maybe you start with one, and maybe that first dinner is still terrible because it did absolutely nothing. But then maybe the next time we try two, and we slowly build up to where we see an effect and where we see a balance between what it does for cough and what it does in terms of side effects and what we can tolerate. Another way to do this is a regular way, the same way like this trial did, where you're on an opioid kind of around the clock, a low dose of it, and we slowly up titrate. We start from almost like almost a non-existent dose, and then we slowly build week after week, and we again find that balance, find that equilibrium. There are safe ways to do this. Oftentimes, the involvement of a symptom physician, or what's called a palliative doctor or palliative care, really what they are is symptom physicians. They are much more expertly in using these medications and up-titrating these medications than any of us strictly ILD-focused people are. So they are often, we often involve them for help with this, and they're often able to keep a closer eye on things kind of from week to week, for example, to say, hey, we need to go up, we need to go down, we need to think about these other things or these other adjuncts to help with that. In terms of other medications, we have non-opioid medications that are similarly, the whole idea behind these is that they're neuromodulatory. They help to dampen that neural reflex arc. There are things like pregabalin or gabapentin. These aren't used in my experience that much, or at least I should say maybe I don't use them as much, mostly because the evidence is probably better for opioids, and we have those on hand. But they similarly dampen that reflex. They're better studied for chronic cough, and they are known to help in chronic cough, especially in non-ILD. So unless you're a total purist, you could probably translate that and say they should also help in ILD, but the evidence is not as good specifically to ILD. Similar side effects, dizziness, fatigue and sedation, sometimes blurred vision. But again, the key to all of these things is to start low and to slowly build that and see where our equilibrium is. Okay, so that's our approach. We basically go for the low-hanging fruit. We're already usually treating your ILD with the thing that we think is best, either anti-inflammatory, anti-scarring, or both. And then if we're really kind of up against the wall and cough is really impacting quality of life, we start to think about things like opioids or those neuromodulatory drugs. The last thing that I should mention that's already been mentioned better than I could is clinical trials, and there are now clinical trials for cough. They are, I know at VGH we're doing them, I'm sure they're doing them at St. Paul's as well. We often participate in similar trials. I will say the thing that I often tell patients is that these, the upside is that you might get access to something that is good and new. The upside is also the altruism of kind of learning about this together and doing better for ILD patients as a collective. The downsides that people sometimes see is that you do have to come into clinic often, and some people don't want to bother with having to come in every month, and that there's usually a half chance that you're on placebo. So those are usually the major kind of pros and cons that I think about with clinical trials if you meet the criteria to be eligible for them. Okay, so putting it all together here, cough and interstitial lung disease, as we all know, has a substantial effect on quality of life. We start with considering and potentially treating, maybe more often than not, these coexisting common problems to see if we can help or what we can help. These treatments have to be continued at least 4 to 6 weeks before we can really rule out that they've helped. So some of these things are those prescription kind of antacids, your neti pod and nasal saline rinse, your steroid spray, your wedge pillow. Treatments for lung scarring with antifibrotics or anti-inflammatories, these will already be on board according to what you need for your particular ILD subtype. Hypersensitivity to cough is notoriously difficult to deal with, but can develop over time with any of these. And when cough is especially terrible and other treatments haven't worked, we may reach for things that dampen that cough reflex to try to help. And the important thing with that, it can be tailored, it is safe to do. We start low and we go slow. And last of all, consider clinical trials. Okay, so I'll leave it at that.